Go ahead.
So this is another presentation. This is a recorded live case. Actually, that was shown on CRT this year, and it's an opportunity to share this with you. So it's an AltaValve case in a box. This is the AltaValve, so it's a nitinol-based device. I briefly showed it before. There is a nitinol stent frame that gets apposed against the left atrial wall. The bottom part of the valve has got the annular ring, which is covered by PET fabric, and that is designed to mitigate PVL. It comes in three different sizes, 40, 46, and 54. And the valve itself is seated in the inside of the device, so it's a bovine pericardial 27 millimeter true size, 27 millimeter valve. This is delivered transeptally using a 29 French delivery system. So it's a single-stage procedure with five simple steps: transeptal puncture in an inferior-posterior position, like with any TMBR, balloon, septostomy. Usually 8 or 10 millimeters is enough. The steerable guide is inserted, 29 French, and then the delivery system is inserted through the guide. The system is flexed down towards the valve and then deployed from the mitral annulus all the way to the roof of the left atrium. There is an internal catheter that you will see during the case, which we call the positioner. Is a 6 French catheter that is actually wrapped around the chimney with a snare and is reinforcing the posterolateral part of the valve in order to maintain stability and position during deployment. So this is our case, typically high-risk patient, 87 female, unsuitable for TEER because of Liefeld calcification and also distribution of the prolapse. It's a DMR case, unsuitable surgery due to MAC as well as high risk. You can see some of the lab values. Patient had some renal impairment, but mostly was in heart failure and NYHA class 3 to 4 with NT-proBNP above 6,000. There is AF and a remote history of GI bleed, but nothing really. And she was able to do 195 meters of 6-minute walk. These are the medication, and she was approved to get into the AltaValve pivotal trial. She was actually number 2 patient, I think, that was enrolled into the pivotal trial. This is the right heart cath, 2.2 liters of cardiac index, moderate or borderline severe systolic pulmonary hypertension, 55, but everything driven by the left side, so PWP 28 with an excessive V wave. The echo, you can see there is a lot of MR, obviously, with prolapsing mechanism. You can see jets coming from the center and also the lateral part of the valve. So there was a prolapse of P2 and P1, and that's what made it quite complex for TEER. And that's why I recruited in the TMBR. Regards fraction was calculated as 100%. That shows the shortcomings of echo evaluation. The ejection fraction was about 46%. Some TR, but not severe. Interestingly, there was a jet that was directed towards the septum, and that made us think twice about the potential iatrogenic ASD. And this is the sizing. So the calcium distribution in the medial part of the valve. The MAC volume was 1,900 cubic millimeters. And actually that qualifies this for the MAC arm of the pivotal trial because by definition, the quantity of the MAC qualifies the patient for that. And some other metrics in the left atrium and the left ventricle. So this patient qualified for the big valve, actually one of the biggest we put. So 54 at the level of the annulus, 85 by 90 millimeters, the cage. So this is the procedure. So you can see the transeptal puncture was actually quite tough to get into the place. So we used an Agilis catheter and electrified a wire to go through in the exact spot because it was difficult to get it with the catheter. So with the transeptal system, you can see a Landerquist wire going all the way to the left upper pulmonary vein, balloon septostomy with a 10 millimeter balloon. And once this is in position, we get the steerable guide, which is 29 French that goes through the septum. It's actually quite easy to go through the septum. You can see the hemodynamics, both aorta and LV recorded at the same time in the bottom left, ECG and echo on the top left, fluoro on the top right. So now the delivery system is inserted inside the guide catheter, and the whole system is flexed down towards the mitral valve. You can see on fluoroscopy some calcification, which is a useful marker. On fluoro, of course, our guidance is the echo. You can see on the left. You can appreciate that there is also on the echo some disjunction of the posterior leaflet, so very complex anatomy. That's why we didn't do TEER. And now gradually we deploy the system from the LV to the LA. So we try to obtain a depth of about 10 to 15 millimeters below the level of the annulus as measured on the echo, mainly on the posterior and the lateral side. So you can see on the left, the echo is posing to get in systole an assessment of the depth, which is if it's about 10 to 15 millimeters, it's okay. Usually the patient remains hemodynamically stable throughout the procedure. Now you can see the annular ring is being deployed, which is like a bulb here. It's a 54 annular ring. Once this is deployed, we push the system laterally to get some engagement against the lateral wall. That gives additional stability. And then we go backwards to deploy the left atrial cage. Once we are at a certain height, we can loosen the internal snare. You can see perhaps that there is this internal catheter. By loosening it, we open up the valve, and now the valve is fully functional, and that will help to maintain hemodynamic stability. And once we have this engagement, then the next task will be to deploy the left atrial cage against the left atrial wall, trying to be reasonably fast. And sometimes we pace to get some bit to bit to eliminate. But as you saw here, there was a pop out. So the valve slipped and went all the way up to the free wall of the left atrium. That sometimes is to be expected. If we can avoid it, we try to avoid it, but it can happen. The valve is designed to account for that. So we can resheath the atrial cage. We can go all the way to the chimney tips, to the tips of the internal valve here, and we can re-snare the internal catheter to reduce the profile of the valve. And once we do that, we will be able, as you can see here, to reflex the system right now. So we reduce the profile, and now we can go down again to the mitral valve by flexing down and monitoring on the echo. And then we can deploy a little bit deeper and trying to also improve our lateral engagement against the lateral part of the mitral annulus. This time we move a little bit faster and we pace at 110 beats per minute. You can see now that by pacing we eliminate bit-to-bit variation and perhaps reduce the stroke volume. Blood pressure is borderline, but it's okay. And then we just very quickly deploy by pushing in the left atrial cage. You can see that now. And this is real time, so we can go back really fast and push the insertion point. You will be able to see the insertion point now. It's being pushed against the rooftop of the left atrium, and then we open up the internal snare by opening the valve, and this is the valve now fully functional. We're able to evaluate the hemodynamics, evaluate the position of the valve, look at the color, and once we're happy, then we're able to remove the internal catheter here, and we will be able in a minute to deploy the valve right now. So the valve is now deployed. You can see that there was some left to right flow, but also some bidirectional flow. We were a little bit concerned about it, so we elected in this particular case to close the ASD. So you will see now a Cardioform 25 millimeter occluder to be inserted to the left atrium. It's actually very easy to close the defect because you've got a very clear fluoroscopy marker, which is the cage against the left atrial septum. So now you will be able to see in a minute the disc deployed in the left atrium there and then pulled down towards the septum, and now the right atrial disc is deployed. You can see that on echo. So the ASD was closed. So device time was 27 minutes, despite the fact that we had to resheath and redeploy. Patient actually did very well, discharged on day 4. And I have to show you the 6-month follow-up. Actually, patient is now almost getting to a year of follow-up, I think, or maybe 9 months. But this is how the valve looks on echo. You can see that there is no PVL, there is nice diastolic flow. Here it is on the long axis view. You can see widely open LVOT, some AR, but no PVL, which is very, very important. So in summary, the AltaValve was deployed as a single stage, low profile 29 French delivery system, conforms to the shape of the LA and MAC. Despite of the MAC, there was no PVL, and actually preserves the LVOT, which is the key message for this valve. The patient that you saw was part of the Atlas pivotal trial that commenced both in US and Europe. We're happy to be part of the leadership of the trial, along with Yoshi Kaneko, Paul Suraja, Leonard Conradi, Vinny Buppet, and of course, the study chair, Ron Waxman. And we did 4 patients in Inter-Balkan, and the first 2 patients done in MHI, Minneapolis Health Institute, and I know more centers are now being activated in US and Europe. So thank you very much for your attention, and happy to answer questions.
Any questions from the audience? Dr. Iacobu.
Vlasi, thank you for this presentation, excellent as always. So, can you elaborate on the issues that came up lately with the AltaValve with the larger sizes? It's something you think it's something to worry about, or it's?
So what happened? There was a subset of cases that had some strut fractures. We had one patient that we had to deal by putting valve in valve. Patient is doing very well, and there was another patient also in the US. I can't remember which center, but I think a total of 5 patients, if I'm accurately informed about it. All patients are doing well. In some of these patients, there was PVL. In our patient, there was significant PVL. That's why we had to do a valve in valve. So we inserted, we went through the septum, through the cage, and we inflated the valve inside the chimney by bridging the gap between the chimney and the annular ring, eliminating the leak. So the leak was coming through the chimney, through the inner valve and the frame. So this has been already reviewed by the engineers of the company, and they realized that the issue was related to the internal catheter. That's why I made a particular discussion about it, and the snare that wraps it around the chimney. So it was felt that during the crimping process, there was excessive force at the base of the chimney, and that created these fractures. So now there is a process that already finished for the 46 millimeter valves and soon for the 54 millimeter valves, that the process of loading has been altered. Bench testing is already completed and submitted to FDA. And very soon the 46, I think in the next couple of weeks, will be released again. We never had any issues with the 40 millimeters. So hopefully once this is done for the 54, we'll be back on track again. It's one of the issues. I mean, that's why TMVR is very, very difficult. I mean, you have big devices, difficult loading conditions. I am aware that other companies face similar struggles, but I think if there is an honest dealing with that and engineering root cause analysis, it can be overcome and we can move on.
There's one more question from the audience, quickly.
That's a very nice presentation, a nice case. Just a question about the long-term outcome, especially in focus of endocarditis. Do you have cases with endocarditis, and what do you think will be the impact of all these cases in case of endocarditis?
Well, it's a very good question. We haven't had a case of endocarditis ourselves. I'm not aware of any case of about 120 valves have been implanted so far, so I'm not aware of any case, but I guess it's not science fiction. Endocarditis may happen as it happens for TAVI. Clearly, removing this valve from the surgical perspective, I mean, Professor Kofidis will know that better. might be a little bit cumbersome by having to disengage the cage from the left atrial wall. Having said that, we had one case that had to be removed, and it was done by our surgeon endoscopically, and patient actually is doing very well. The valve was removed, I think, after 4.5 months, so it was feasible. Long-term outcomes, there are from the transapical cohort, because this valve started transapically and then moved in septally, transfemorally, that are up to 4 years out. And there are no issues with the integrity of the leaflets and the hemodynamic performance on the valve to the patients that are making it. We have patients that already are 2.5 years out, and they are doing well.
Vlasi, any comment about anticoagulation? I assume they're on warfarin.
So we start them on warfarin mandatory for 6 months, and then we switch to NOACs or whatever the patients were taking before. Actually, most people are scared about anticoagulation when they look into all this metal in the left atrium, but really the anticoagulation is for the leaflets, as for any other bioprosthesis, because the cage is nitinol, and we're familiar with nitinol with the ASD PFO devices is not really thrombogenic, but nevertheless 6 months of warfarin and then followed by NOAC is what we normally do. Most of these patients are in atrial fibrillation anyway.
Well, any other comments? No. Thank you very much, Vlasis. This was
Thank you.
An excellent
Pleasure.
presentation, both for this valve and the whole TMVR.